Welcome to the Regional Health Solutions podcast, powered by STATIM.
We're your hosts, William Mundt and Jaden Frame.
So today's podcast is a little bit about the background of STATIM.
One of the questions we get is, why did we start STATIM? So the background of STATIM was two guys coming together, both with different healthcare experiences, and understanding that the healthcare landscape in regional rural Australia is broken. And how do you fix something that's broken? And so Will and I spent a good 6 months before we set up STATIM to work out what is it that we can change and influence that will actually help the sustainability of healthcare in regional rural Australia. We sort of quickly identified that the livability of a regional and rural town is actually hinged or underpinned by the sustainability of health or the health system. Without a good health system in regional rural Australia, the livability decreases. So that the mass migrations to our regions, there's a strong need to build the livability of regional rural Australia by improving the sustainability of healthcare, and that is why STATIM was created, and that is our why. So a little bit about me. My background is I'm finance and business. Spent a number of years in the bank, and then started working with my wife and a business partner in a small allied health business. We had a bit of fun with that business, and 8 or 9 years later, we sold it to a private equity group. So I have an experience around what large health businesses, how they operate, and following that, I went and set up the health division at a economic development organisation in regional Australia. So that role led me to work with a number of executives and CEOs of private public hospitals, government and PHNs, and gave me a unique experience of the challenges and barriers that we face in regional rural Australia. So when I saw the dynamics and the challenges that cohort had, it got me thinking on how does private enterprise play a role in improving the sustainability of healthcare in regional rural, and then ultimately underpinning the livability of our regions. If you live and work and generate revenue from a regional rural town, what's your obligation from a personal and a business point of view to invest in healthcare? So picking that thread and finding like-minded people is how Will and I actually came to co-collaborate and eventually build STATIM.
It's a little bit about my background. I've been a nurse since 2006. I started as an AIN in Toowoomba, one of the private hospitals here. So I've been a nurse for coming up to about 20 years and have done multiple roles, everything from AIN right through to Director of Nursing of one of the hospitals here. Before we started STATIM, one of the projects that I was on was a national project across 10 private hospitals in Australia. It's around developing a definitions manual, actually, which sounds incredibly unsexy, across 10 private hospitals. And a definitions manual was more to make sure that each of those hospitals had a unified strategy, a benchmarking capacity, and to find sustainability across that private organisation that I work for. And I got a lot out of that. I recognised that nothing can actually be achieved without strong relationships and collaboration. And the learnings I got out of that was that, yes, you can unify 10 private hospitals and you can make them all sing the same song and dance the same dance and be able to collaborate together. However, any role, my personal ambition then to move from that was that I recognised that any role I pursued internally within a private organisation was relatively only going to limit what impact I could make within that private company. And so my brain kept reeling and trying to determine what would be the most efficient way to actually start to map some of these learnings and efficiencies and the idea of sustainability across not only 10 private hospitals, but begin to influence things like the public sector or the aged care sector, and potentially even then the NDIS and the private allied health sector within health services. And the answer I kept coming back to was that my logic was the only way to do this was to start up a private business. And much to Jaden's point, we'd had a business relationship over the last 10 or so years. We'd crossed paths when Jaden was at Wise Therapy, and I was the NUM of a private hospital in Toowoomba, which utilised those services. And recognised that our values heavily aligned, and just serendipitously, it seemed that at that point that I was coming off the back end of that project, he had the same fire in his belly, having also performed similar roles where it influenced across multiple stakeholders within the Toowoomba LGA or the Darling Downs LGA to actually begin to look wider at what sustainability looks like. So STATIM was created off the back end of Jaden and I coming together and working out how we could begin to infiltrate and influence systems, processes and sustainability of facilities within individual regional or rural LGAs. We whiteboarded a lot of ideas, and every time we came up with an individual idea, it always came back to the same thing, and that was that healthcare underpins the livability of a region. However, it's actually the people, not the bricks and mortar, that actually drive the industry. So whatever we came back to, workforce always seemed to be the underpinning catalyst as to what made the healthcare sustainable within the region.
And we looked at a lot of things, didn't we, Will? Things we looked at, and we still are looking at, common themes that we see in regional rural. It's infrastructure. You've got an ageing infrastructure, which there's a $900 million investment by the state government over the last couple of years with upgrades to, in our region, Tara, Millmerran, potentially Chinchilla. We've got a new hospital in our region. So infrastructure, but supporting infrastructure that isn't necessarily a Queensland Health or a federal spend around step-down care or subacute step-down care or workforce accommodation are all things we're looking at. Transport, how do you actually move between infrastructure and can that be done better or a value add that can be looked at? Is it navigation? How do you navigate through the process? They're all common themes that need multiple stakeholders to be talking, which is all challenging when your major stakeholder in the industry, if you take Toowoomba for an example, you've got Darling Downs Health, which do a great job. They're 50% of industry, which is a government-owned industry. Include the two private hospitals, which are about 5% of FTE. You have greater than 40% of the industry is probably small business. So you've got 50% of the industry governed by government. How do you influence and grow an industry when government have such an influential hand on the wheel, and the 40% that rely upon workforce and infrastructure and transport are actually small businesses without the capability and capacity to drive those changes themselves? So how do we coordinate that is a key point that Will and I look at and going, there's a place for private industry to play here and partner with key stakeholders to drive change in our rural and regional areas to increase the livability of our centres, which then roll on to other industries that if you increase your livability, your gas, your ag, your education sectors can then attract good people to the regions, and you have this ecosystem, which we're really trying to drive. So our hope with developing this podcast is we don't want 25,000 listeners on this channel. We want 150 to 250 of regional leaders that are looking to change healthcare in the regions, and this will serve to be a communication and a information session that we understand driving between towns to towns. If you're a CEO of a HHS or a minister of a portfolio and you're driving between Tara and Chinchilla and you've got an hour to kill, you're on the phone, maybe the phone doesn't work, that you can put on a podcast and you can listen to what innovative solutions are actually happening in regional rural Australia. And if you need to, you can connect with that person directly because they might be doing something cool in Chinchilla and you're looking at something in Ballarat that you might go, well, that will work. And I need to talk to that leader who's driving that. Feel free. It's a connection line for innovative business leaders in healthcare, and feel free to contact us at the office. And I'm more than happy to connect relevant leaders around the country to drive that innovation in different states and regions and centres. So when Will and I sat down and worked through the challenges in rural and regional healthcare, we looked at numerous things. Everything revolved around workforce. You can't do anything without workforce. And what we like to say is we're more than an agency, and our commercial model allows that, and we understand how agency is a bad name and how it isn't sustainable. So how we actually play a role to drive that and looking at different innovative solutions, particularly in the Darling Downs, around workforce solutions. And at the core of everything we do, because sometimes you don't get things right, is strong relationships. And developing strong relationships with key stakeholders is STATIM's number one rule. And understanding where people are coming from, understanding who the customer is and what your common goal is what STATIM's about and is probably our secret sauce in what we do. So when we start to unpack workforce in our region, you look at the hospital. We've got a new hospital coming into Toowoomba in the next 2 or 3 years, and potentially the 30 to 45% uplift in workforce requirement. Where are those people going to come from? And how do we do that? And how do we do that sustainably in partnership with key stakeholders?
What I want to think about is taking a step back and actually realising that workforce, as to what I said earlier, workforce is the absolute driver to make sure that healthcare is sustainable. And again, right back at the genesis of STATIM, the last thing we actually wanted to do was create another agency out there that was popping up on every corner and is on the nose with every industry. Again, having been on the other side of it as an assistant director or director of a hospital, the general rule is agencies cost more per hour. They're not one of your staff, so they're generally less familiar with your processes and policies. They're less likely to onboard. And to be quite frank, it actually starts to erode culture because you don't have your team working with people that they know. So, as I said, the last thing we wanted to do was actually create an agency. However, we recognised that because of these exact pressures, if no one else was taking on that model and attempting to change it for the better, then we had an obligation to try, particularly given our why is liveability and sustainability of healthcare. So basically from the ground up, we rebuilt the model of what an agency should and could look like, including starting with the basics like quality control of the clinicians and even really basic things like doing a behavioural-based interview to make sure that these were quality clinicians, not only clinically, but they were good fundamental people who had good values-based decision-making, to make sure that when a STATIM nurse arrives at a facility, it's well known what the quantity is that they're going to expect to receive. In terms of onboarding, one of the big points of difference that we really quickly made a decision on was that if we hand on heart had a interest in the facility that we were servicing, tradition within the agency world is that there's generally a $10,000 or a $20,000 recruitment fee should that person want to onboard with the facility. If we genuinely wanted to see the pipeline grow within that facility for workforce and coupling to that had the clinician's interest at heart, then introducing a fee like that, one, is not only double dipping, in my opinion, clipping the ticket on the hourly rate and then clipping it on the way out, but it's unethical and it's actually introducing friction into a system that creates an us and them mentality between agencies and facilities. So we quickly established a commercial model within our service level agreements with each of the facility that makes sure that that's sustainable both for them and us and challenges, I suppose, those old rusted on ways that agencies historically have operated. If I can take a step back, one of the biggest sources of blame comes to COVID when we talk about costs and sustainability. I still think there's some lingering effects from COVID, no doubt, like the increased costs of consumables and that stores pipeline has definitely not slowed down. CPI has rose and so has the cost of everything. However, EBITDA maintenance within our facilities haven't changed. There's still pressure and expectations that EBITDAs get maintained. And if you liken it to any household, if you want more savings, you can do one of two things. You can either shave your way of living or you can increase your revenue. You can increase how much income comes into the household. And again, anecdotally, I know that private health insurance, just talking from a PHI perspective, PHI contributions have only marginally kept up with CPI to our private hospitals. So therefore, the only way to maintain EBITDA is to decrease the costs of the way that care is delivered. And when 70 or 80 cents in the dollar is workforce, that seems to always be the most obvious place to start. When when we're talking agency spend, sometimes in facilities that we see of 5, 10, sometimes 15%, that becomes a very, very unsustainable model where flex staffing is sometimes 150% of the dollar per hour rate. So again, making sure that these commercial structures are sustainable for facilities is what is paramount, and what our obligation in that fight, I think, is. And where we're seeing a lot of inertia when we talk to facilities is to say, well, even if you said per hour rate is on par, having these other bolted on effects that mean they're saving money in other ways, such as recruitment and feeding their individual workforce pipeline, means that there's an offset somewhere in a value add that isn't purely dollar per hour.
So, yeah, and mate, let's just throw it out there that, and it's something we're actively doing at STATIM, is we're actually trying to reduce the agency market. If we do our job right, as we were saying, it's unsustainable at current levels in regional rural Australia, so we're actively reducing our market. That seems to be ridiculous when we've set up a business in the last 2 years. But if these facilities aren't there in 10 years' time, our market's gone and our livability of our regional rural towns disappears. So how do we do that? And that's when we start looking at a facility that we've been working with for 6 months, a private facility around Toowoomba. We've been working with them on one of our mentoring programs, and to get feedback around that their agency cost has gone from a six-figure sum per month to a low five-figure sum per month means to me that they're going to be there for the long term, and they're going to be providing care to those residents of that community for a longer time.
So STATIM's model, when we talk back at the start, the last thing we wanted to do was create an agency. The second last thing we wanted to do was create a consulting company. I think the last thing that some facilities need at the moment is someone coming into their facility, giving them 60 recommendations on a polished report and walking out the door and not working alongside the facility, 59 of which are probably the facility's individual ideas that they've recycled. Hence why we wanted to create a more hybrid model that said, well, we can definitely help with immediate workforce requirements, and we've already gone through the points of difference where we can make sure that that's not just a replication of what every other agency out there is doing. But again, generally, workforce and roster deficits don't just appear overnight. Generally, they are a symptom of something deeper, whether it's a clinical process or a cultural anomaly or some sort of strategy or financial consideration. So with the depth of experience in the office and deliberately recruiting high-quality clinicians, STATIM quickly recognised that we had a depth to our capability, and we were reluctant to just simply blindly fill rosters from now until the end of time. We actually wanted to get into the trench with the facilities that were experiencing these pressures to say, well, hey, how can we reduce your agency spend? And much like Jaden said, we have runs on the board now and some testimonials and experience with examples of where this has occurred. So run some examples through when we sat and we sat with the Darling Downs Health team, recognising that the new Toowoomba Hospital is 3 to 4 years away before turnkey, with a 30 to 40% upswing in activity. That's not only clinical but non-clinical workforce that's going to have to be found to be able to service the facility. So right now, if they're 3 years away from opening the doors, some of those nurses, just to double down on the clinical space, are actually sitting in grade 10, 11 or 12 within the high schools right now. And the logic is, if you are not the first industry, if you're the second, third or God forbid, fourth industry to move to try and get some of these kids and young adults into the healthcare industry, you are already going to be behind the eight ball. It's not actually important, I don't think, right now, whether or not they get into nursing or medicine or allied health or clerical work or an orderly or a housekeeping. It doesn't matter where they end up. The big dial to dial is to get them into healthcare, and health and aged care for that matter, and persuade them that that is the career path they want to go down. The smaller knobs come later on, where you dial them up to make sure that they are satisfied then in being in the career they want, whether, again, it's nursing or non-clinical or whatever that is, which led to the evolution of a product and program that we run at the moment, which is micro-credentialing. So we've partnered with, and again, testament to our first value, which is strong relationships. It's going to be a theme throughout this whole podcast series that you'll hear from the half a dozen people that we talk to. Strong relationships are the underpinning of everything. So talking to Fairholme College in Toowoomba, there's at least 40 or 50 students who have gone through and done a Cert 3 or 4 in some sort of health discipline. And there's this vacuum of time, this 12 or 18 months vacuum of time before they actually get out and practice clinically. And the feedback that we were getting is that it's 12 months, one, of inexperience where they're de-skilling and unlearning the things that they did learn that were fresh in their mind when they finished the Cert 3. But these girls also had a fire in their belly to actually get into the industry and get a leg up and start their career. So we are also partnering with St Vincent's Care Services, who going to take these girls on a micro-credentialing course, which fills the softer skills like resilience training and even back to being able to perform at an interview, and gives them 4 weeks worth of one-on-one mentored time with a registered nurse, gets them familiar with the paperwork and the processes within that facility, completely free of charge to the facility. And then the facility gets the first option of onboarding these students at the end as a fully qualified AIN. Chances are as well, because they're already, this is the big dial I'm talking about, because they've already made the decision to get into the industry, the likelihood is that these girls are eventually going on to do nursing or some sort of allied health undergraduate, which means this is the secret, I think, to feeding. We all talk about growing our own. I'm not sure that it's actually done innovatively or very well. If we're actually talking about growing our own, I think it actually starts at the high school and getting this blended model back of what once upon a time was hospital-trained nurses, along with the academic side of things.
Yeah, well, really good point. And we do growing your own well in the region. It's actually it's connecting them after they're actually educated is where I've seen the gaps historically, where yes, they may go out and do their placement in Chinchilla, but then because the university they're going to is based in Brisbane where they live and breathe, then they go and get a job at the PA. So this micro-credentialing program, it actually connects them to a local industry in healthcare. We give them an experience where it's enjoyed and it's mentored and it's a good experience. It's a good landing zone that when they arrive in that facility, they're mentored with an RN. The facility are getting access to workforce, but they're also have the ability to reduce their agency costs, because that potentially that role that is getting filled it may be an agency. So this program is growing their workforce, reducing their agency costs, and connecting young kids who are already in the regions and live in the regions. So you remove that housing issue to a facility within the regions to build a workforce pipeline, which is so important. And we've just started this program and we're really looking forward to sharing the results when our first cohort graduate. Well, just elaborating on what you're saying around our strong relationships, and that is one of our core values, strong relationships. But the way we do that with a facility and a clinician is we partner with them. Again, we don't like to say we're agencies and we don't like to say we're consultants. We're partners with our facilities and we work arm in arm and hand in glove. So what's that look like? So a consultant typically comes in, charges their money and gets out. We're like the neighbour that won't leave, or the guest in the house that won't leave. That sometimes we do things that aren't commercial, which is pushing against the grain, but we don't make money out of everything. Our why around sustainability and growing the workforce or increasing the livability of regional Australia, commercialising everything is not what we're doing. What's the right thing to do, and how do we partner with a facility in the long term that gives that sustainability for both STATIM and the healthcare facility? So they're models we're looking at developing, what that looks like. If anyone out there wants to partner with STATIM and see what that looks like, feel free to reach the office. We're happy to have discussions and look at what that look and feels like. A lot of people ask, what's STATIM? What does it stand for? Why did we actually choose STATIM as the name? So STATIM is a Latin term for stat right now. It's a medical term. And
who gave you that?
Mate, Big Red, that was you. So it's stat right now. Healthcare is extremely reactive, and when you want a solution, you want it right now. So that's where STATIM came from. Our byline, Regional Health Solutions, is what we do. We provide regional health solutions. How that looks is different in every regional centre, but it does underpin the livability of a region.
Yeah, and solutions are not a one-size-fits-all model. You talked about the reactivity of healthcare and the reactivity of facilities at the moment. And unfortunately, I think that is the direction that healthcare has gone, because we've gone away from preventative medicine. Primary healthcare has not been the focus in Australia for probably the last 10, 20, 30 years. And it is at a flashpoint now where the cost of healthcare is indicative of how reactive we are. The metric of how sustainable and how well healthcare is delivered in a region at the moment is how functional the hospital is and how many beds in the hospital you have, which is actually the ambulance metaphorically at the bottom of the cliff. And we're not as focused at the moment as we should be on the sign at the top of the cliff. So my intuition is that there's going to be this inertia in the next 5 to 10 years, and it's probably already happening, to focus more on not only primary healthcare to prevent this reactivity to people's health on the healthcare continuum, but also reactivity comes from everyone individually trying to solve very similar prickles that they're all sitting on. And I'm not even actually talking healthcare discipline specific that influences the healthcare of the region. And I'm going to just elaborate on that for a second. One thing that STATIM has worked with UniSQ on over the past 6 months is with their data and analytics team. And our vision is to create what we are calling a STATIM Score, which is a sustainability of healthcare index within every LGA within Australia, every rural LGA within Australia. What that looks like is taking a holistic view of the LGA to make sure that we're not missing any moving part of what actually influences healthcare within the region. So what does that look like? Industry drivers within the region. What are the commodities within that region that make sure they have a strong commercial structure? What's the social connectivity within the region? And even down to things like transport and childcare. Workforce obviously has a seat at the table. Clinical care availability has a seat at the table. How many clinicians are in the area with specialised skill sets based on PHN trending data? So amalgamating all of this up into some sort of algorithm and sustainability index, a STATIM score, will eventually help governments make strong decisions on where money needs to be spent to actually solve the sustainability crisis within each of these LGAs. So what that drills down to is obviously collaboration and relationships within everyone who has a hand on the wheel within the healthcare continuum. We're all responsible for our individual driver, whether it's length of stay within the acute sector or it's presentations for GPs. Arguably, though, everyone has this Venn diagram overlap of what the journey and the experience of the individual within each of these areas actually looks like. However, we're all trying to solve that in a different way. And if I keep doubling down on workforce as the example, I can think of a small town outside of Toowoomba. It has a private aged care facility, it has a public aged care facility, and it has a public hospital. Now, arguably, each of those facilities are servicing a different type of clientele. So they are not in direct competition with each other to look for patients or residents in beds. What they are in direct competition over is workforce. They're all competing for the same nurses or allied health or housekeeping or ward clerks to come and work within their facility. However, each of those facilities would each have a different individualised workforce plan to attract and recruit staff. This is where inefficiencies, I think, creep in, and we start competing with each other. And again, back to where I started with this is where I see the evolution of health going to be less reactive and more proactive and collaborative, to work together to go, well, rather than us all compete over the same thing or have different strategies for the same thing, how do we come together and make sure that we're all swimming in the same direction? That's what STATIM is trying and beginning to achieve, is actually bringing facilities and organisations together to actually collaborate and work on similar problems to get better outcomes.
So if you're listening to this podcast and you're working on an innovative regional health solution and you wanted to connect and broadcast your solution or look for partners, feel free to reach out to STATIM at www.statim.com.au. More than happy to have a conversation and put you on our podcast for the next series, connect you with government, connect you with local government, federal government and a local LGA to potentially broadcast your message and replicate your innovation at different locations around regional rural Australia?
We're really excited to bring you this first season. So this first season is going to have 6 episodes with exactly as Jaden just described. These are thought innovators and leaders within the Darling Downs region. And we're going to publish a new one of these every fortnight. So make sure that you're following that Regional Health Solutions podcast in your podcast app so that you can get new episodes automatically once they're released. And we look forward to hearing from prospective guests on the show. Stay connected with the conversation about enhancing livability through sustainable healthcare solutions for regional Australia. Visit statim.com.au/podcast to learn more, connect with us and join the movement towards a healthier future for our regional communities.